We are going to discuss congenital diaphragmatic hernia today. The first thing is congenital diaphragmatic hernia. What is meant by the term CDH? So it refers to the herniation of the abdominal contents into the thorax, mainly through a posterolateral defect that is also known as CDH by the name Bogdalek hernia. But if we go by this is the Bogdalek hernia. But if we go by history of the CDH, so it was first described in 1754 by Macaulay. He was an associate of uh, Hunter. He described about the CDH first time in the history. Then Cooper described in 1827, and then Linneck, who the gentleman who discovered the stethoscope, described in 1834. Actually, and then later on in 1847, Bodic described and also gives the how to diagnose it bedside. The Bogdalek actually was wrong in the interpretation and the about the interpreting the embryology of the congenital diaphragmatic hernia. He described that it is because of posterolateral rupture of the membrane, where it leads to separation of the pleuroperitoneal canal into two cavities, which was actually wrong interpretation, but the name is still continues. So basically, the most commonly defect is seen through the posterolateral defect, which is around 95%, and the less common are the Morgagni hernias and the and the central diaphragmatic defect sometimes. So, if we talk about the laterality, the commonest side is the left side, that is around seen in 85% of the cases, and the right side are associated with 10 to 15% of the cases. Bilaterally seen in 2% of the cases. Then the basic embryology is it is because of failure of the pleuroperitoneal folds to fuse during the fourth to fifth week of the gestation, and this failure of pleuroperitoneal folds lead to compression of the lungs by the herniated abdominal viscera, which enters into the defect, and it causes slowing, or I would say hampers the broncholar and the vascular branching, and ultimately leads to lung hypoplasia and pulmonary hypertension, which has impact in overall management. And now if we talk about the prenatal management, so the prenatal management, majority of cases, because of the availability of all those investigations and the routine anomaly scan, the around 60% of these cases, CDH, are detected antenatally with the help of anomaly scan. And what are the prognostic factors which determines or which predict the postnatal survival? So the first thing is syndromic association, where the karyotype abnormalities are seen in around 20% of the cases, and the most commoner ones are trisomy 18, 13, and 21. And the syndromic association, if we see, there are many syndromes. The commoner ones are the Fryns syndrome, which may have additional malformations. Then the second thing is presence of additional malformations. So the commonest anomalies or the commonest malformation that are seen with the CDH, whether the child are postnatally alive, or they are like when they are alive for a certain time period, and then because of the abnormalities they died. The commonest anomalies are the neural tube defects, and the second commonest are the cardiovascular anomalies. Now, the third prognostic factor, which is very important actually, is the liver herniation, and that determines overall prognosis, especially in cases of the left-sided CDH. So in the left-sided CDH, if there is a presence of liver as a content of the sac, it determines that it's associated with poor prognosis. Right-sided, the liver will be universally present, so it is not as a predictive factor. And then the fourth and the most important thing is fetal lung volume. So fetal lung volume, whenever this fetal lung volume is less than 30% of the expected volume, that means there is a poor post natal survival. So what we do, we calculate lung head ratio, and that is how it is calculated. It is calculated with the help of either USG or MRI. So we calculate lung head ratio. It is the contralateral lung, which is the less affected lung, at the level of atria. The circumference is measured, and then it is divided by the head circumference. So and then is normalized for that particular gestational age, and then observed upon the expected lung head ratio is calculated. And if the value is less than 15%, that means that it is extreme. And if it is 15 to 25%, that means it is severe. And if it is 25 to 35%, then it means it is moderate. And if it is 35 to 45%, that means mild. So higher the value, that means the good is the lung head ratio, which helps us in predicting that there is a chances of improving survival with increasing observed to expected lung head ratio. Then what are the other factors? So other factors are for example, one of the important factor is early age at the diagnosis. So early gestational at the diagnosis. Then second thing is stomach herniation. Then right sided CDH. So left sided CDH do better than the right sided CDH, but they are like this is has been not proven with the help of studies, but with the outcomes it has been uh, mentioned in few articles. Then people have tried to do in utero management of these anomalies, especially the fetal tracheal occlusion, that is also known as feto, to improve the survival in isolated severe, that we have already discussed what is meant by severe left sided CDH. That trial was the total trial by an AGM. So it was a multicentric randomized trial, where, and it was conducted in the centers which have a good experience in feto procedure, comparing the feto at 27 to 29 weeks of gestation with the expectant management, especially in those fetus which have severe left sided CDH. And then it was found that there was a improvement in the survival to discharge among the infants, those who underwent feto, around 16 babies out of 40, that means 40%, and compared to expectant group where it was seen in only in 6 babies out of 40. But they have also shown that there is an increased risk of pre-labor rupture of membranes and preterm births in the group where the feto was done. So preterm births are around the percentage is 75% versus 29% in the control arm. And then the preterm and premature rupture of the membrane, that was seen in around 47% versus 11%. So if now we'll discuss about the postnatal management. So postnatal management, so one should remember that this is a medical emergency. When the child is born, one has to take care of the respiratory parameters. So it is a medical emergency rather than a surgical emergency. So delivery should be conducted at a tertiary care center with high volume. And what is meant by high volume? That means that particular center is seeing around 6 CDH cases in a year. And delivery should be conducted at or beyond 39 weeks of gestation. And the mode of delivery should be guided by the obstetric indications. That means like there is nothing called as that one has to do cesarean section. Then one may ask, what is the role of antenatal steroids? So antenatal steroids and surfactant therapy is usually like given as we give in other babies like less than 34 weeks. Then we have to consider depending upon the institutional protocols. Then there are few things which we have to remember during delivery. So first thing is respiratory care. So what we all going to see in the respiratory care, that is intubation at birth if it is needed. That means one should not rely upon mask ventilation and should not do avoid it. It's a contraindication. Then second thing is use low peak presses. Low peak presses means that it should be less than 25 centimeter of water to achieve a good ventilation. And that is by good ventilation that the preductal SpO2 should be 80 to 95%. Then we'll see what is meant by preductal and the postductal SpO2. Then the supportive care include insert a NG tube to decompress the bowel loops which are there in the thoracic cavity, and the chest compressions and the medications as per the neonatal resuscitation protocol. And the third and the most important thing is one should avoid paralytic agents. Basically it is like avoid any thing which is causing stress, which include light, sound, anything. Then shift the baby to NICU. And if NICU, what we are going to see, so the respiratory care in NICU targets include the preductal SpO2 and the second is postductal SpO2. So preductal means a vessel which is before the ductus arteriosus, which we can see here in this image. So this is patent ductus arteriosus. So the blood which is going from here, that means to the right arm or right ear lobe, and when it is going here, then one can see in the any of the feet. So that is postductal. So that is postductal SpO2 and that is preductal SpO2. So the value of preductal SpO2 should be less, should be around 80 to 95%, and postductal should be more than 70%, and a PaCO2 of 50 to 70 mmHg. Then if the child is ventilated, what should be the preferred mode? So preferred mode is the conventional assist control mode. The conventional assist control mode with a volume target where one can initially keep it as a around 4 to 4.5 ml per kg with the settings the peak inspiratory pressure should be less than 25 centimeter of water, then P should be around 4 to 6 centimeter of water, and the respiratory rate should be around 40 to 60 per minute, and FiO2 depends upon what is your SpO2. So it should be that we have already discussed the preductal and the postductal SpO2s. And if like with all these settings one are not able to achieve the required parameters, then one can shift to the rescue mode, and this rescue mode actually includes the high frequency ventilation, then the second and the most important thing is hemodynamic care. So hemodynamic care include the blood pressure for the particular gestational age, and there should be no signs of hypoperfusion, and then which include there should be CFT should be less than 3 seconds, there should not be any poor pulses, urine output should be good, that means more than 2 milliliter per kg per hour, lactate value should be less than 3. Then if all these targets are not achieved, then one should look for echo for the functional assessment, and saline boluses 10 ml per kg depending upon, and one should be cautious while giving fluids. So if the vasoactive agents are required, and then dobutamine, milrinone, and adrenaline depending upon what is needed, and management of associated PPHN, that is pulmonary hypertension, should be according to the protocols that we are going to discuss in some other class, or if needed in the second part of the video. And the third important thing is supportive care. What supportive care? So the vascular access includes umbilical arterial catheterization or umbilical venous catheterization. So one can switch to PICC lines also. Then nutrition, parenteral nutrition, and initially the fluid should be restricted around 40 to 60 ml per kg on day 1. Sedation. About sedation I have already discussed that one should avoid any kind of noise, light, tactile stimulus, and one has to shift on the opioids. The rates or the doses are for fentanyls, it is around 1 to 4 microgram per kg per hour, and for mid or plus minus midazolam can be given, that is around 10 to 60 microgram per kg per hour, and avoid paralytic agent because this is going to affect your the ventilator mechanism. So if all these after all these, when the medical stabilization achieved, so either it can be achieved or it cannot be achieved. So if it is achieved, then what you are going to do? So what are the parameters that we have achieved? So the parameters are preductal SpO2 should be 85 to 95% on FiO2 less than 50%. The first thing. The second thing is Blood pressure should be normal for gestation. And then the third thing is lactate should be less than 3 millimole per liter. And the fourth thing is urine output should be 2 ml per kg per hour. And if it happens, then one can proceed with surgical repair, which can be either a thoracoscopic repair or either can be a open laparotomy repair, depending upon the institutional choices. And the repair can be either primary repair, the sutures alone, or with the help of Gore-Tex patch or a split abdominal wall, a muscle flap, especially where there are the large defect, for the large defect. But one should always try to look for the primary repairs, because it has its own role with the growth of the baby, because your graft or the patch is not going to increase in the size. So with this you have to remember the most important thing: there is no role of routine ICD placement. Okay, so there is no role of routine ICD placement. That is very important. But what happens if all these parameters are not achieved? So then here comes the role of ECMO. So ECMO, what we are going to do? So for example, your PIP is more than 28 centimeter of water, and still the neonates is having inadequate oxygenation. That means your preductal SpO2 is still less than 85%, and the postductal SpO2 is less than 70%, and oxygenation index is more than or equal to 40 for at least 3 hours, and your pH is persistently showing metabolic acidosis with pH is less than 7.15, and a lactate value more than or equal to 5 millimole per hour, and a refractory shock which is not responding to fluid and the vasopressor therapy, that is persistent shock. So these are the condition where one has to shift to the ECMO. Then one has to follow the ECMO protocol. So one has to do surgery with the ECMO protocol. Then post-operative period, what we have to look for in the post-operative period. So post-operative period, we have two challenges. One is acute post-operative care, and the second is long-term care. So post-operative care, acute, slowly wean off the ventilation as tolerated, slowly wean off the ventilation, and monitor for persistent pulmonary hypertension, and if it is there, then follow the protocols to manage it, and also look for whether there is any signs of like hemorrhage, chylothorax, and infection. And one should consider feeds when the child is clinically stable and there are no gastric aspirates. Usually around POD 3 to POD 5 one can initiate these feeds. The long term care includes one can look system wise. So the first thing is gastrointestinal GI system. The most common symptom within the first year of life after the CDH repair is the GERD, the cause of readmissions. Then if it is a graft placement, Gore-Tex placement, then the chances of CDH recurrence, poor growth and obstruction. And in pulmonary or the RS, respiratory system. There will be a restrictive or the obstructive lung disease. Infections can be there. Then in cardiac system, there can be persistent pulmonary hypertension, should be managed as per the protocols, whatever the drugs are needed. Then the neuro developmentally, there can be cognitive defects, behavioral problems, and the ADHD like symptoms. And in hearing, SNHL can be there, and chest deformities along with the scoliosis can be seen with a growth scoliosis. So these are the like overall management algorithm for a neonate who was born with congenital diaphragmatic after birth. So thank you for the today. We'll discuss further topics in the next classes.